Okay, so for my empirical article, we focused on conduct disorder. I read a 2019 review by Gotti and colleagues that really examined more than 3 decades of research on psychosocial treatments for conduct problems in children and adolescents. Children and adolescents were going to be the main two subgroups that they had for dealing with this disorder. The article focused specifically on identifying which interventions were empirically supported and what makes them effective. And since our topic is conduct disorder, this article was really helpful because it looked at real world treatment, not just the theory or diagnostic criteria. 4 big takeaways that I really found from this article are going to be that no single problem is the best. However, treatments are most effective when they're developmentally targeted, and age is very important. They separated this into ages of 11 and younger and 11 and older. For younger children, so that childhood onset, that would be generally under the age of 11. And with this, they found that the parent-focused programs showed the strongest results when dealing with intervention programs. These included parent management training, parent-child interaction therapy, and programs like Triple P or Helping the Non-Complaint Child program, which all taught parents how to modify interaction cycles that often reinforce a child's misconduct. The research also consistently shows that this has decreases in aggression and noncompliance, and the effects can last often months or years after treatment is over. For older youth, however, that would be that adolescence range for 11 years old and up. They found that focusing on child-focused cognitive behavioral programs tended to be more effective. These programs really targeted more children's decision-making, problem-solving skills, anger regulation, and social information processing. These problems were the problem-solving skills training, the anger coping problem, and the coping power program. And they all ended up showing reductions in disruptive behavior and delinquency, even at 1 year follow-ups. But the age-specific emphasis was really heavily articulated that it's not like a one-size-fits-all for these cases and intervention programs and what will have the best long-term results. Um, Building off of that intervention, early intervention is really essential for focusing on that childhood onset group, especially since they are more at risk for developing more maladaptive long-term behaviors down the road. So it's really important to get a handle on those with some preventative programs, which are only really in place for these childhood onset disorders because they can lead to things like substance abuse, violence, and even just antisocial personality disorders. We also found, or the article also found, that psychotherapy is still going to be the first line of treatment for conduct disorder diagnoses. Medications are sometimes used for cases with aggression, but the article really emphasized that the evidence supports only a pharmacological treatment if it is absolutely needed and it has limited availability. They really focus on that psychotherapy action as it can help actually get rid of those behaviors rather than just take away some of the symptoms of the diagnosis.
I had the psychosocial interventions in the treatment of child and adolescent conduct disorder by Tonali, Goker, and Uneri, and it also went over the interventions for conduct disorder and found very similar results with emphasis on the age being the determining factor in the effectiveness of treatment, with children responding better to parent interventions and adolescents responding better to multi-systemic therapy, which means therapy in their family life, their school life, and their community life. I think the emphasis on parent interventions for younger children is important because their behaviors have not fully set in yet. And I think that's the change that happens in the adolescent interventions, where you see the interventions need to specifically address their behaviors and how they interact with the world around them, and less so how the world around them impacts them. The most effective or examples of the multisystemic therapy included uh, juvenile detention programs or specific schools for children with conduct disorders, which had classrooms of 5 to 8 individuals, as well as a teacher and a specific therapist, as well as a therapist that would talk to the child and the family and uh, join those two areas together versus with children. The most effective treatment was with discussing with the parents and getting the parents to change how their behaviors interact with the child and how the child's behaviors affect the parents. So creating a better system of getting the parents to react in more constructive ways to the children and forming a better relationship between the two. I think that was really shown in the risk factors for conduct disorder with uh, parental depression and substance abuse being big risk factors for conduct disorder, as well as low performance in academics and substance use disorders. And I think that the crossover between our articles really show the importance of developmentally targeted therapies and interventions.
Hmm. Yeah, I'd say that's really going to be like the main takeaway from both of them, from what it sounds like. Going off of some of what you were saying with like the family focused therapy interventions, I thought it was really interesting how it was mentioned in my article as well, how the effort and involvement of the parents is really important. There aren't always going to be those circumstances or situations where a parent is ready to be involved in this treatment. Are also some situations where a child may be the age where this sort of treatment is the most preferred and seen as effective, of course. However, they have a parent who is taking part in abusive behavior or that disinterest or disinterest in participating at least, which can also like harm that area or like harm that plan of action and show like a lesser effect for those people.
Yeah, I think it's that plays into as well the how our articles talked about the effectiveness of each treatment. Um,
Mhm.
with some treatments being super effective in the short term, but lacking in the effectiveness in long term, or
Mhm.
vice versa, where the results aren't seen immediately, but it would appear that long-term outlooks are pretty good.
Mhm.
A example in this in my article was with a fake courtroom where parents would defend their children's actions in a court of law or a fake court of law, and then the children would also get to speak. It showed very high effectiveness in the short term, meaning the conduct disorder symptoms, the children showed remission in those. However, in the long term, they still reported those behaviors. And I think that the article covers like the scared straight programs in that uh, sometimes the effectiveness is it appears more effective in the short term than in the long term.
Mhm. Yeah, I feel like mine also really touched on not only just like the differences in long-term effects for the different programs, but how much more research needs to be done to evaluate these. It actually compared a couple different studies that were done outside of the scope on delinquent criminal cases and things of that nature. And with those control and groups that received that treatment or intervention plan, they actually interviewed them again 24 years later, and it was seen that the control group who received no intervention was demonstrating higher symptoms associated with long-term effects of conduct disorder or conduct behavioral issues. Whereas the group that received intervention was showing, oh wait, no, the control group was showing better expectations, and the group with intervention was showing that more of those factors.
Hmm. Yeah, I think that's really important to mention.
Mhm.
All right,
Perfect.
ready. I'll end the call now.